let's move on. The next one is, the next thing they are going to be doing now is what? The hypertension. Okay. So what are we going to do? We are going to give IV antihypertensive. Give IV intravenous, because this one, I mean, the BPs are high. IV antihypertensive. But in some jurisdiction, they use what? Nifedipine. Or rather, plain nifedipine to control. But nifedipine also has, I mean, a lot of side effects, okay, which may not augur well for the patient. But in some jurisdiction, it's used cautiously, okay. But IV, you know, IV works a bit faster, so we can give what? IV antihypertensive. In this case, that is hydralazine. Hydralazine, okay, 5 milligram. 5 milligram every 30 minutes. Every 30 minutes until diastolic blood pressure is 90 to 100 millimeters of mercury. Until DPB is 90 to 100 millimeters of mercury. You know, the indication for the use of hydralazine would be what? When the diastolic blood pressure is greater than or equal to 110 millimeters of mercury. Is that clear? Are we following? When the diastolic blood pressure is greater than or equal to 110 millimeters of mercury, you should use the hydralazine. Are we getting that? In other cases, you can use labetalol. Are we getting that? Are we following? Okay. Now let's move on. There's something that we are supposed to do again. It's pass urinary catheter. Pass urinary catheter. We are supposed to, please pay attention. After we spoke about the max sulfate regimen, the next thing should have been what? Passing urinary catheter. So let's take note of that. I will give you the reason when we are done. So after the max sulfate regimen, okay, giving max sulfate, the next thing you're supposed to do is what? Pass urinary catheter. Most of these things are done, they are done in tandem, they are done together, okay? That's why we say you should call and assign roles, okay? So pass urinary catheter to monitor, not urinary, pass urethral catheter. Urethral catheter, pass urethral catheter to monitor urine output. There's a reason for that, we'll talk about it. Then the next one is you give IV antihypertensive. I said that is if the diastolic blood pressure is greater than or equal to 110 millimeters of mercury, you give hydralazine 5 milligram every 30 minutes, right? Every 30 minutes until the blood pressure. What's the maximum dose you can give? Is what? Yes, 40 milligram. Maximum dose is 40 milligram. Okay, so if the diastolic blood pressure drops, you also have to stop. Okay, and orals can also be used, as I was saying. Okay, the reason why we are passing the urinary catheter is because of magnesium sulfate toxicity. When we are done, we'll talk about that. Okay. So we give the, as we said. Then the next thing, yes. And I said labetalol can also be used. In other cases, you can use labetalol. Labetalol, the dose is different. Labetalol, you use 20 milligram. Okay, 20 milligram. And that labetalol can be given every 5 to 10 minutes. Okay, so in this case, when you give the 5 milligram of IV hydralazine, the next time you give will be 30 minutes. So you are supposed to be monitoring the BP every 5 minutes until 30 minutes. Are we getting that? And if the BP is still high after 30 minutes, you will repeat the dose in that order. Is that? And I said that in some jurisdiction they use oral nifedipine. It's oral nifedipine. Okay. So it's not only the hydralazine that can be used. Labetalol can be used, and oral nifedipine can also be used. Okay. So the next thing is going to be dependent on whether the patient, the gestational age. Okay. So that one will give corticosteroids again. Okay. So here I am the dexamethasone. Okay. To mature fetal length, if gestational age is less than 34 weeks, give I am the dexamethasone. We know the dosage already, 6 milligram, 12 hourly for 48 hours, okay? to mature fetal lungs if gestational age is less than 34 weeks. If it's less than 34 weeks. You said? They do 6 milligram BD, that's twice daily or 12 hourly for 48 hours. Okay. Then the next one. And that's what we are going to be doing. You monitor vitals. You monitor vitals. Monitor vitals, such as maternal blood pressure, pulse, respiratory rate, very, very important, respiratory rate, temperature, urine output, very, very important, very, very important. Urine output, very, very important. Here to add deep tendon reflexes, very, very important. Deep tendon reflexes, very, very important. Then also fetal heart rate, fetal heart rate, fetal heart rate, very, very important. Fetal heart rate. Let's add there to fetal key count as well. Fetal key count. We'll add there to daily albumins, daily albumins, daily albumins, daily albumins, daily albumins. Then the next one, deliver. At what gestational age are you supposed to deliver? If let's say gestational age is less than 34 weeks.
That's 7.
So you deliver, okay, you deliver at 34 weeks, okay, of gestation. If gestational age is less than what? 34 weeks, or deliver. If the gestational age is less than 34 weeks, you deliver by 34 weeks. Are you getting that? You cannot wait to go to 37. If not, the worst can happen. Are we getting that? So you deliver at 34 weeks. If gestational age is less than 34 weeks, or by 37 completed weeks of gestation, if the gestational age is greater than what? 34 weeks. No, let's not add that. Because the reason why I'm saying let's not add that is because of what we are going to do. Indications for immediate delivery. If the gestational age is greater than or equal to 34 weeks, it's immediate delivery. So let's put it this way. Deliver at 34 weeks if gestational age is deliver at 34 weeks if the gestational age is less than 34 weeks, or deliver immediately if gestational age is greater than 34 weeks. That should be more appropriate. Deliver at 34 weeks if gestational age is less than 34 weeks, and immediately if greater than what? 34 weeks. If greater than or equal to 34 weeks. Or immediately if greater than or equal to what? 34 weeks. Vaginally or via CS. Vaginally or via CS, cesarean section, based on indications. Based on indications. The next one, you switch to oral anti-hypertensive. Hold on, what did he say? Okay, so please, you see where we spoke about the antihypertensives. Okay, where I was saying that if the diastolic blood pressure is less than is ranging 90 to 100 millimeters of mercury, at that point, when it happens like that, you cannot stop giving the patient antihypertensive. You have to switch toward oral antihypertensives. Are we getting that? Are we following?
Yes, sir.
So let's take note of that. When we give the antihypertensives, once the blood pressure goes below the threshold, goes within the threshold that we set, then we'll switch toward oral antihypertensives. Is that clear to you? Now, so after you've delivered, okay, that's fine. But other things that could be done is that after delivery, the patient should still be kept, okay, in the labor ward for about 4 to 6 hours. Don't add, just take note, about 4 to 6 hours, and be monitored and see whether there will be any manifestations. And after that, she will be sent to the lying-in ward and be monitored from there. The blood pressures has to be monitored. You will still have to do the PET labs again after delivery to check if everything is fine. Are we getting that? And that would determine when you should discharge the patient. And for a pre-eclampsia patient, you may have to keep them for at least 5 days if everything is fine before discharging them. Are we getting that? All right. Then the next thing I want us to talk about is when you are giving magnesium sulfate, it could precipitate what we call magnesium sulfate toxicity. Okay. So before you give max sulfate, what parameters are you supposed to look at before you give? You are supposed to look at certain parameters before you give the max sulfate. Okay. The first one is what? The presence of deep tendon reflexes. You want to check if the deep tendon reflexes are there. Okay. Parameters before, what you should consider before giving max sulfate. Okay. The next one is the respiratory rate should be greater than or equal to 12 per minute. Then the last one is the urine output. The urine output should be greater than or equal to 25 mils per hour or greater than or equal to 100 mils per 4 hours. Plus or minus intranasal oxygen. Plus or minus intranasal oxygen. That is uncontrollable BPs, uncontrollable hypertension, uncontrollable blood pressures. Okay, so if they are uncontrollable blood pressures, you have to deliver immediately. Or that's what we call refractory severe hypertension. Is that clear? Severe hypertension means greater than or equal to what? 160 over what? 110 in obstetrics. But internal medicine will be what? 160 over what? 100. Is that clear? Okay, so that's the first one. The next one, we'll say deranged PET labs. We've spoken about PET labs, right? Right? We said pre-eclampsia toxicology screen labs, which consists of full blood count, blood urea, electrolyte and creatinine, liver function test, and serum uric acid. We said that. Yeah?
Calcium chloride, 5 mils.
No, calcium 10 mils. It's the same volume. The same volume as the calcium gluconate. The calcium chloride is more effective. It's more effective than the calcium gluconate, just that the side effect makes it less advantageous than what? The calcium gluconate. Okay, so deranged PET labs is an indication for what? Immediate delivery in severe preeclampsia. The next one is gestational age. That's what I was telling you. Gestational age greater than or equal to 34 weeks. It's an indication for immediate delivery in severe preeclampsia. Is that clear? The gestational age, that's why we have to correct that. You get the point? The next one, when there is ascites. Okay, ascites, which you have confirmed with an ultrasound scan. Okay, or an examination. Or ultrasound scan, yes. The next one, anasaka. The patient has become entirely swollen. Sometimes when you check their vulva, it is swollen, very huge. Okay, you check sacral edema, pedal edema, facial edema. Every part of the body is swollen. If you touch any part, it is what? Pitting in nature. Okay, that is anasaka. If there's anasaka, yes, you have to what? Proceed. Again, if there is an acute pulmonary edema, yes, you have to proceed. If there's fetal distress, yes, you have to proceed. You have to proceed. There's fetal distress, you have to proceed. Okay, you have to proceed. Again, if there's, it's dependent. Depending on what is there. If the services can be ripened, why not? if you can ripen the cervix, the only thing is that when you are going to deliver vaginally, you have to shorten the second stage of labor by using forceps or vacuum delivery. Are you getting that? By using the forceps or vacuum extraction. Are you getting that? If you are going to use, because you have to expedite the expedited route. CS is fast, but if the cervical state is showing that it is going to be possible to expedite delivery vaginally, why not? But the only thing is that make sure the second stage of labor you shorten it. Is that clear? Okay. Now let's move ahead. Let's talk about eclampsia now. Or let's talk about complications of pre-eclampsia. Then after that we'll talk about eclampsia. Yes.
So the marks of what would be the alternative in case the patient cannot take it because of
if the marks of it, if the patient cannot contraindicated, then you have to correct. If you are seeing signs, those signs already before, then you have to correct them before you start giving. But the marks of it is the preferred. In this case, highly preferred. It's highly preferred. It's the first line. You can use other if there's seizure, yes, you may be forced to use other anticonvulsants like diazepam, phenobarbital. Okay? But again, the first line should marks off it. First line is marks off it. Okay? Please, can we continue? Let's talk about the complications of pre-eclampsia. Then after that, we'll look at eclampsia. Then that will be it for hypertension in pregnancy. We'll have a short break. When we come back, we'll look at cervical cancer. That should not take us long. Should not take us long. Then we'll close the chapter on obstetrics and gynecology. Yes. I mean, as I told you, the contraception, we use the question to tackle that. And also I'll comment on gestational diabetes later on, not today. Okay. Comment on that. Hopefully on Friday. Okay, I should comment on that. So it means next week we'll be looking at internal medicine on Monday. The Tuesday we'll look at internal medicine. If you are done with everything, then as I said, we'll look at questions. Okay. Okay. When we are done, I will comment on the mock. Okay, I'll comment on the mock. Complications. Complications of pre-eclampsia. Complications of pre-eclampsia. This one there, you should be telling me. Yes. Huh? Eclampsia. We'll come here. Well, let's leave it. Let's leave the eclampsia at the last, so that when we are done, we'll just look at it. Okay. So we'll talk about Hep Syndrome. Hep Syndrome. So Hep Syndrome is just basically an acronym. Okay. Hep Syndrome. Who can tell us what is? H for what? And how will you be able to certify that? On peripheral blood smear. So, what are you going to see? You are going to have abnormal, smear, abnormal peripheral blood smear, abnormal findings of peripheral blood smear. Which abnormal findings are you going to have? Right. There is going to be what? What evidence are you going to have? You have the presence of what? You are going to have what we call a chinocyte or bear cells. A chinocyte. A chinocyte or bear cells. Bear cells. What are bear cells? On peripheral blood smear. On peripheral blood smear. On peripheral blood smear. What are bear cells? Oh, okay. Bear cells or chinocyte, they are basically crenated. Okay. So they are crenated red blood cells. They are basically crenated red blood cells. Crenated. Okay. And bear cells, do you know how they are? Do you see the red blood cells developing what? Spikes. Or spicules. We call it spicules. Okay. The spicules will be spicules. But the spicules, you see the spicules, those projections, they will be evenly spaced. The chinocytes or the bear cell, they have evenly spaced evenly spaced spicules on the surface of the red blood cell. That's what we call echinocyte or bare cells. Bare cells. They are indications of what? Hemolysis. Okay. Please, are we getting that? Okay. We can also see acanthocytes. What are acanthocytes? Acanthocytes on peripheral blood smear. Acanthocytes, they are also crenated red blood cells, but the only thing is that the spicules are not evenly spaced. Are we getting that? The acanthocytes, they don't have the spicules evenly spaced. The spicules are unevenly spaced. Is that clear? Okay. So these are all crenated red blood cells. The two, they are all crenated red blood cells. Okay. Then we can also see schistocytes. What are schistocytes? Schistocytes. So you see the red blood cell becoming distorted and with a what? A two-pointed edge. Okay. This is what we call schistocytes. Okay. The shape of the distorted shape of the red blood cell with what? Two-pointed what? Edge. Two-pointed edge. They have double pointed edge. The two edges are pointed. Okay, that's what we call schistocytes. They are evidence of what we call microangiopathic hemolysis. Is that clear? So if you are saying schistocyte, you should know that there's a microangiopathic hemolysis ongoing. Is that clear? Please, are we clear on that? Microangiopathic hemolysis. Okay? Okay. Then also, with the hemolysis too, we can look at what? The bilirubin. The bilirubin, serum bilirubin. Bilirubin levels will be greater than 1.2 milligram per deciliter. Anytime you are converting from milligram to deciliter, always make sure you multiply by, it's a complex calculation, but it's not complex. You multiply by, what is the multiple of 4? Multiples of 4? 4.
8.
12. Okay, that's fine. So we'll take the first two. So we'll say 4, 8, 8. So we'll say 88.4. So every time you multiply, if you are converting from milligram per deciliter to micromoles per liter, you multiply by what? 88.4. And if you multiply, those of you who are mathematically oriented, if you multiply 1.2 by 88.4, you should have 106.8 thereabout. So we'll keep it like this, 106 micromoles per liter. Okay? So that's the value you are looking at. Okay. Which one? No, this one is milligram per deciliter. If you are converting from milligram per deciliter, you normally multiply by what? 88.4. And that will give you approximately 106 micromoles per liter, or if you want the decimal, you can be talking 106.8, so thereabout. Okay. So please, are you following? Okay. Then again, you also have lactate dehydrogenase or lactic acid dehydrogenase. Anytime the red blood cells are, undergoing degradation, the lactic acid dehydrogenase is liberated. Red blood cells also contain what? Lactic acid or lactate dehydrogenase. And lactate dehydrogenase will be greater than what? 600 international units per liter. Per liter. If you want to talk about the School of Further Studies, we can say that Hep syndrome can be classified into what? By Hep syndrome has various classifications. This is what I'm telling you right now is what we call the Tennessee. Okay, we have the Tennessee. Okay, the Tennessee classification. We have two classifications of Hep syndrome. We have what they call the Mississippi classification, and we also have what the Tennessee classification. Okay, not to waste time. If you are interested, another time I will tell you about all of them. If you are interested, I will tell you. If you are interested, yes. We have the class 1, 2, and 3. And the class 1 is the severe. Class 2 moderate. Class 3 mild. That's for the Mississippi. But for the Tennessee, it's very simple. They said that if you are good, if you understand mathematics, then you can. There are several ways to have, product from here, help. So the Mississippi, this is what it does. He said that, okay, we have HE. There's only what? Hemolysis and what? Elevated liver enzyme. There's no low platelets. Then we also have LP. only low platelet, the rest are normal. You also have, how do you call it? ELLP. Okay, it's just, this is the Mississippi the Tennessee classification. Are you following? Then we also have the HELP itself. Okay. So it's just breaking the parts down. This is what we call the Tennessee classification. But the Mississippi classification, it classifies them in class 1, 2, and 3. Class 1 being the most dangerous. For the class 1, we can look at it. We can talk about the lactate dehydrogenase will be greater than 600 international units per liter. The AST will be greater than or equal to. Okay. The LDH is greater than or equal to 600 international units. The AST will be greater than or equal to 70 international units per liter. Another time, if you are interested, we can talk about that, so that we don't waste the time. The Mississippi classification and the Tennessee classification. Or somebody can look for this and put on the page. As I said, it will be there. All right, that's fine. So this is for the hemolysis, the evidence of hemolysis. Are we getting that? Then now, the next one is EL. Please, not the EL that you know. EL referring to what? Elevated liver enzymes. You'll be surprised. We will say all these things. Then during oral examination, you'll be asking the candidate, what does Hep Syndrome stand for? They will be telling you that about social studies, where help can be achieved through whatever means. So for the elevated enzymes, we are thinking of, look, so the first one we can think of LDH. LDH greater than or equal to 600 international units per liter. Then AST. Not only AST, the ALT too, but mostly we use AST. Will be greater or equal to 70 international units per liter. Some places they use 72, but to make everything whole, we use 70. Exactly. Exactly. Can use 70 or 72, but 70 is the standard. The Tennessee classification of HELP, they use 70. Mississippi too, they were using 70. So we'll stick with the 70. Okay. So these are liver enzymes that you are looking at. Is that clear to you? Then the last one is low platelet, LP. No liver, no lumbar puncture, low platelet. Okay. You're surprised. For low platelets, evidence by what? If you do the platelet count, what should it be? Platelet count should be less than or equal to 100 times 10 to the power 9 per liter. Or if you like mathematics, then you can say that it should be less than or equal to 100,000 per microliter. Exactly. Exactly. Yeah. But if you want to go further, then we will look at the Mississippi and the Tennessee classification of what? Yes, Hep Syndrome. As I said, Mississippi will divide them into what? 3. Tennessee will divide them into severe and what? The moderate or severe. It will divide them into. The Tennessee classifies the Hep Syndrome as complete Hep Syndrome, where you are going to have everything there, which is Hep, or the incomplete or partial. That's where you have the fragment. So if anytime you see EL and all those separately, that's what? Incomplete or partial Hep. But if you see Hep in full, that becomes complete Hep Syndrome. Yes.
So for the liver enzymes, is there any reason for using only these two?
Is it?
The liver enzymes, is there any reason for using only these two enzymes?
No, I told you that ALT will still have the same rise, but AST is most preferentially deputed. Okay, most preferentially deputed. So it has to do with what? Hepatic necrosis, actually. Anytime there's necrosis in the liver, the response to that is what? Elevated liver enzymes. Okay, that is for Hep Syndrome. Hep Syndrome, they will come with malaise, they will come with nausea and vomiting, they will come with right upper quadrant pain and all that. Okay, mostly you want to treat conservatively. I mean, you want to give pain medication, you want to hydrate as well. Okay, that's fine. Let's move on to the next complication. The next complication, you can think of DIC, disseminated intravascular coagulopathy. We can also think of an acute kidney injury, AKI. Another thing that you would think of should be what? What else do you think of? Yes, you are right. Abrasion Placenta. Because if you remember very well, we said, when we were talking about abrasion placenta, we said the revealed is associated with what? We said the revealed abrasion placenta is associated with what? Pre-eclampsia, right? Another one. B. Postpartum hemorrhage. Well, no, it's not a main complication, but it could be, yeah, it could be, but it's not. Yes, acute pulmonary edema. Yes, acute pulmonary edema. Acute pulmonary edema. Acute pulmonary edema. Yes, what else? Yes, cardiovascular accident. Cerebrovascular accident, not cardiovascular. Cerebrovascular accident. Okay, it has to do with the pathophysiology that we said. Okay, there will be what we call ischemic encephalopathy. So we can add it here. Ischemic encephalopathy. Okay, so it means that it's going to be more ischemic in nature than what? Hemorrhagic. Okay. Then the last one we'll talk about eclampsia. Eclampsia. Okay. Now let's talk about eclampsia. The last one that we'll go for break. Eclampsia.
No fetal.
Is there?
No fetal complication. Maybe IUFD.
Oh, this one we are talking with regards to the mother. If you are looking at the fetal complications, all these are going to go for the mother, maternal complications. But if you are looking at fetal complications, we can talk about fetal distress. This is maternal complication. Now let's talk about fetal complications. Fetal complications, you can think of what? Fetal distress, prematurity, IUGR. That's intrauterine growth retardation or restriction. Fetal distress. Fetal distress, IUGR, prematurity, fetal death in utero. All right, that's fine. In some certain cases, you may also, think of. But those ones are going to be. We can think of. Those ones will come with. How do you call it? To the developing fetal brain. To the developing fetal brain, there will be static changes. In the long term, if that baby is delivered, may or may not develop cerebral palsy or hypoxic ischemic encephalopathy. But that's fine. These complications are fine. Okay. Yes, please. For which one? After delivery, yes. Fetal distress in utero. So, but mostly, if you are talking about acute respiratory distress syndrome, it has to do with the surfactant.
Yeah, because maybe if the patient comes with indications for immediate delivery, you may have to deliver before 34 weeks of the.
So that will be a consequential. It will go with the prematurity aftermath. Okay.